Hi, thank you for participating in this study. In this module, we are going to look at medications to treat tobacco use dependence. This module focuses on patient education and the proper use of medications for tobacco cessations. It will focus on the medications that are used in this project. The information provided in this module derives primarily from the product package inserts and the National Guidelines for Tobacco Dependence Treatment and Cessation that was published in 2017. This study is a partnership between the Kisumu Ministry of Health, the Kenya Medical Research Institute, and the University of California, San Francisco. The National Authority for the Campaign Against Alcohol and Drug Abuse, NACADA, and the Ministry of Health are collaborators in this study. Funding is provided by the US National Cancer Institute grant. A significant portion of the content was adopted from the UCSF's Treatment for Change and the San Francisco Health Network. The objectives in this module are 1. To discuss medications that support tobacco use cessation, and 2. To discuss prescription and patient education related to tobacco dependence treatment medications. Tobacco dependence is a chronic condition that requires a two-pronged approach for maximal treatment effectiveness. In the previous module, we addressed the behavioral change program. In this module, we are addressing the medications for cessation. Tobacco cessation medication help manage the physiologic aspect of tobacco dependence. These agents work by alleviating the symptoms of nicotine withdrawal, which include irritability, anxiety, difficulty concentrating, restlessness, depression, insomnia, impaired task performance, increased appetite, weight gain, and cravings for tobacco. This slide depicts the general time course for common nicotine withdrawal symptoms that is observed following the cessation of tobacco use. Most withdrawal symptoms manifest within the first 1 to 2 days, peak in intensity within the first week, and gradually subside within 2 to 4 weeks after cessation. In some individuals, prolonged appetite effects such as hunger or weight gain may occur continuously for 6 months or more, and strong cravings for tobacco can persist for months to years after cessation. For this reason, the typical recommended duration of therapy for pharmacotherapy is 6 to 12 weeks. This helps to alleviate the symptoms of nicotine withdrawal during the early stages of quitting. When patients are more comfortable, it is easier to address the habits and routines associated with tobacco use through use of cognitive and behavioral coping strategies. For additional information, please refer to the Assisting Patients with Quitting module. There are 3 general classes of approved drugs for cessation. Nicotine replacement therapy, abbreviated as NRT, includes the nicotine gum, nicotine patch, nicotine lozenge, nicotine inhaler, and nicotine nasal spray. The only psychotropic agent currently approved for smoking cessation is bupropion. Varenicline, a partial nicotinic receptor agonist, was approved in 2006 for smoking cessation. In Kenya, these are the tobacco use cessation medications. 3 types of nicotine replacement therapy available over the counter. That is the gum, the lozenge, and the patch. And bupropion is available by prescription. In this module, we'll only address the medications available in Kenya, with a focus on the medications used in this project. The rationale for using nicotine replacement therapy in tobacco cessation include the following. NRT reduces physical withdrawal symptoms associated with nicotine cessation. NRT increases success by alleviating physical nicotine withdrawal symptoms, which are usually experienced following tobacco cessation. This makes patients more comfortable while they are quitting. NRT eliminates the immediate reinforcing effects of nicotine that is rapidly absorbed by tobacco smoke. NRT allows the patient to focus on behavioral and psychological aspects of tobacco cessation. While NRT products are helping to alleviate withdrawal symptoms, the patient is able to focus on the behavioral and psychological changes necessary for successful tobacco cessation. NRT itself can be addicting, and although the addictive properties are negligible compared to tobacco products, some patients might have difficulty terminating NRT use. NRT use significantly improves the success rates of smoking cessation, and that combining two types of NRT medication improves success rates. Because these medications are intended for use to prevent withdrawal, it is essential that patients adhere to a fixed dosing schedule. Advantages of NRT include the following. Patients are not exposed to the carcinogens and other toxic components found in tobacco and tobacco smoke. Secondly, NRT provides lower, slower, and less variable plasma nicotine concentrations than do cigarettes, which reduces the behavioral reinforcing effect of smoking. The nicotine lozenge is available in two strengths, that is 2 milligrams and 4 milligrams. It is a resin complex of nicotine and polacrylene. The lozenge is meant to be consumed like hard candy or other medicinal lozenges. Because the nicotine lozenge dissolves completely, it delivers approximately 25% more nicotine than does an equivalent dose of nicotine gum. Like the nicotine gum, the lozenge also contains buffering agents, that is sodium carbonate and potassium bicarbonate, to increase salivary pH, thereby enhancing buccal absorption of the nicotine. The lozenge rapid absorption allows for acute dose titration as needed for nicotine withdrawal symptoms. The recommended dose is 5 lozenges every 6 hours to a maximum of 20 lozenges per day. Patients may use 1 lozenge every 1 to 2 hours for the first 6 weeks of treatment, then gradually reduce the number of lozenges used per day over the next 6 weeks. Note that the recommended starting dose depends on the patient level of addiction, measured by how long it takes for the patient to use tobacco after awakening. If they use tobacco within 30 minutes of awakening, start with 4 milligram lozenge. If they wait more than 30 minutes after awakening before using tobacco, start with the 2 milligram lozenge. We are not using the nicotine gum in this project, but we'll discuss it here since it is available over the counter and some patients may buy it. It is available in 2 milligrams and 4 milligrams, often with flavors such as mint. The gum is made with nicotine polacrylex, which is a resin complex of nicotine and polacrylene in a sugar-free chewing gum base. All gum formulations contain buffering agents, that is sodium carbonate and sodium bicarbonate, to increase salivary pH, thereby enhancing buccal absorption of nicotine. In summary, the advantages of nicotine lozenge, which we are using in this project, and gum include the following. Might serve as an oral substitute for tobacco, e.g., satisfy oral cravings for tobacco. Might delay weight gain. Can be titrated to manage withdrawal symptoms. Can be used in combination with other agents to manage situational urges or cravings for tobacco. Disadvantages of the gum and lozenge include the following. Need for frequent dosing can compromise adherence. Gastrointestinal adverse effects, such as nausea, hiccups, and dyspepsia, might be bothersome. Disadvantages specific to the nicotine gum formulation might be problematic for patients with significant dental work, e.g., gum might stick to dentures, braces, fillings. Proper chewing technique is necessary for effectiveness and to minimize adverse effects. Gum chewing might not be acceptable for some patients. The nicotine patch is available in 7 milligrams, 14 milligrams, and 21 milligram strengths. In this project, we'll be using the 21 milligram and the 14 milligram strengths. It is a 24-hour nicotine delivery system. The transdermal nicotine delivery system consists of an impermeable surface layer, a nicotine reservoir, an adhesive layer, and a removable protective liner. Nicotine is well absorbed across the skin, with 68 to 82% of the dose released from the patch reaching the systemic circulation. Plasma nicotine concentrations from the patch rise slowly over 1 to 4 hours and peak within 3 to 12 hours following application. Blood levels of nicotine achieved with the transdermal patch are lower and fluctuate less than do those achieved with tobacco products or other NRT formulations. The dosing schedules for the nicotine patches vary. In general, persons who smoke heavily require higher doses of nicotine. Although each of the currently marketed formulations uses a tapering course of therapy, No evidence indicates that gradual weaning is more effective than abrupt discontinuation. Furthermore, significant differences in long-term cessation were not observed among studies comparing different durations of nicotine patch therapy. When patches applied for 16 hours were compared to patches applied for 24 hours, no significant differences were found in quit rates. However, one study found that patients with strong morning cravings for cigarettes might be more successful with a patch applied for 24 hours. Shortly after applying the nicotine patch, patients may experience irritation at the patch application site. The irritation might be in the form of mild itching, burning, or tingling. These effects are common and generally resolve within an hour. Additional possible side effects include the following: abnormal or vivid dreams, insomnia. Patients should be advised to remove the patch at bedtime if these adverse reactions become troublesome. Advantages of the nicotine patch include the following: once daily dosing is associated with fewer adherence problems. Of all NRT products, its use is least obvious to others. Can be used in combination with other agents, that is, it delivers consistent nicotine levels over 24 hours. It is relatively inexpensive compared to other treatment approaches and is generally less than the cost of a pack of cigarettes. Disadvantages of the patch include: when used as monotherapy, it cannot be titrated to acutely manage withdrawal symptoms. It is also not recommended for use by patients with dermatologic conditions such as psoriasis, eczema, or atopic dermatitis because they are more likely to experience skin irritation. Nicotine activates the sympathetic nervous system, leading to an increase in heart rate, blood pressure, and myocardial contractility. Nicotine may also cause coronary artery vasoconstriction. These non-hemodynamic effects of nicotine have led to concerns about the safety of NRT use in patients with established cardiovascular disease, particularly those with serious arrhythmias, serious or worsening angina, or those patients in the immediate post-myocardial infarction period within the past 2 weeks. Bupropion sustained-release tablets are an oral antidepressant medication used as a non-nicotine aid to smoking cessation. Bupropion is an atypical antidepressant thought to affect the levels of brain neurotransmitters, e.g., dopamine and norepinephrine. The purported mechanism of action include blockade of neuronal reuptake of dopamine and norepinephrine in the central nervous system and through antagonism of the nicotinic acetylcholine receptors. Bupropion may also function as a nicotinic receptor antagonist. These actions clinically result in reduced craving for nicotine and symptoms of withdrawal. Recall that the dopaminergic system is thought to play a role in self-reinforcing behavior, that is the reward pathways and dependence, whereas noradrenergic effects are thought to prevent the symptoms of nicotine withdrawal. Let's take a look at the pharmacokinetics of bupropion. Animal data suggests the absolute bioavailability of bupropion ranges from 5 to 20%. Bupropion undergoes extensive hepatic metabolism to three active metabolites. One of the metabolites, hydroxybupropion, is formed by the cytochrome P450 isoenzyme CYP2B6. Bupropion and metabolites are eliminated in urine 85% and feces 10%. Less than 1% of an oral dose of bupropion is excreted unchanged in urine. The half-life of bupropion is 21 hours, and that of its metabolites is 20 to 37 hours. Steady-state plasma concentrations of bupropion are reached within 8 days. Efavirenz and ritonavir are CYP2B6 inducers, and in combination with bupropion could increase the metabolism of bupropion, thereby reducing the steady-state drug concentration and its efficacy. Thus, for patients who are using efavirenz and ritonavir in any combination with other agents, will be offered combination NRT. The following are contraindications for the use of bupropion. In patients with a seizure disorder, while seizures are an important potential adverse effect associated with bupropion therapy, clinicians should know that the reported frequency of seizures with bupropion in clinical trials for smoking cessation is 1.5 events per 1,000 people taking bupropion. While seizures are relatively rare, bupropion should not be used in patients with a seizure disorder. The drug should be used with caution in patients with an increased risk of seizure, including severe head injury, arteriovenous malformation, CNS tumor or CNS infection, severe stroke, concomitant use of other medications that lower the seizure threshold, such as other bupropion products, antipsychotics, tricyclic antidepressants, theophylline, and systemic corticosteroids. Metabolic disorders such as hypoglycemia, hyponatremia, severe hepatic impairment, and hypoxia, use of illicit drugs such as cocaine, or abuse or misuse of prescription drugs such as CNS stimulants. Bupropion is also contraindicated in patients who suffered a myocardial infarction in the previous 2 weeks. Use of MAO inhibitors intended to treat psychiatric disorders such as isocarboxazid, phenelzine, and tranylcypromine concomitantly with bupropion or within 14 days of discontinuing treatment with bupropion is contraindicated. There is an increased risk of hypertensive reactions when bupropion is used concomitantly with other MAO inhibitors. The use of bupropion within 14 days of discontinuing treatment with a MAO inhibitor is also contraindicated. In patients with a current or prior diagnosis of eating disorders, e.g., bulimia or anorexia nervosa, as a higher incidence of seizures are observed in patients treated with the immediate release formulation of bupropion for bulimia. The most commonly observed adverse reactions include insomnia, which occurs in 30 to 40% of users, dry mouth, which occurs in 10% of users, and nausea, which also occurs in 10% of users. These adverse reactions might be minimized by reducing the dose. Insomnia might be minimized by avoiding bedtime administration. Adverse effects that are less common but sometimes lead to discontinuation of treatment include nervous system disturbances, primarily anxiety, difficulty concentrating, nervousness and tremors, constipation, and skin disorders. Please consult with the pharmacist, as bupropion should be used with caution in patients with an elevated risk of seizures, including severe head injury, arteriovenous malformation, CNS tumor or CNS infection, severe stroke, and concomitant use of other medications that lower the seizure threshold, e.g., other bupropion products, antipsychotics, tricyclic antidepressants, theophylline, and systemic corticosteroids. Bupropion also should be used cautiously in patients with severe hepatic impairment. In these patients, a reduced frequency of dosing is required because peak bupropion levels are substantially increased and drug accumulation is likely to occur to a greater extent. The dose should not exceed 150 milligrams every other day in these patients. Bupropion should be used with caution in patients with underlying neuropsychiatric conditions. According to the manufacturer's prescribing information, serious neuropsychiatric symptoms including changes in mood, including depression and mania, psychosis, hallucinations, paranoia, delusions, homicidal ideation, aggression, hostility, agitation, anxiety and panic, as well as suicidal ideation, suicide attempt, and completed suicide have been reported. Patients and caregivers should be advised to stop taking the medication and contact a healthcare provider immediately if agitation, depressed mood, or changes in behavior or thinking that are not typical for the patient are observed, or if the patient develops suicidal ideation or suicidal behavior. Clinicians should be aware that the patients with serious psychiatric illness, e.g., depression, schizophrenia, bipolar disorder, can also benefit from use of bupropion while quitting smoking without significant increase in neuropsychiatric adverse events associated with bupropion. The starting dose of bupropion is one 150 milligram tablet each morning for the first 3 days. If the initial dose is tolerated, the dosage should be increased on day 4 to the recommended maximum dose of 300 milligrams per day, given as two 150 milligram doses administered at least 8 hours apart. Doses above 300 milligrams per day should not be used. The recommended total duration of therapy is 7 to 12 weeks. For patients experiencing side effects with the 300 milligram per day regimen, data suggests that 150 milligrams per day is better tolerated and exhibits comparable long-term efficacy. The advantages of bupropion include the following. Oral dosing is simple and associated with few adherence problems. Might delay weight gain. Bupropion might be beneficial for use in patients with coexisting depression. Some data suggest that use of bupropion may increase long-term cessation in smokers with past depression. It can be used in combination with NRT agents. It is relatively inexpensive, generally less than the cost of a pack of cigarettes. The disadvantages of bupropion include seizure risk is increased, several contraindications and precautions preclude use in some patients. Patients should be monitored for neuropsychiatric symptoms. The nicotine patch serves as the backbone for combination therapy because it provides a consistent release of nicotine throughout the day. Short-acting nicotine replacement products such as the lozenge are used as needed for nicotine withdrawal symptoms or when patients experience situational urges or cravings for tobacco. Combination NRT should be reserved for patients smoking more than half a pack of cigarettes per day, and the starting dose of the patch should be 21 milligrams per day for the initial 4 to 6 weeks and tapered over an additional 4 weeks. Short-acting nicotine replacement agents are dosed using the standard doses for the products, but rather than being administered on a fixed schedule, they are only used every 1 to 2 hours if needed for a breakthrough nicotine withdrawal symptom. When providing medication counseling, clinicians should emphasize the importance of adherence to the medical regimens. This includes three key facets. One, selecting the correct strength of the medication. For the non-prescription NRT products, the number of cigarettes smoked per day must be assessed for selection of the nicotine patch strength, and the time to first cigarette of the day must be assessed for selection of the strength of the nicotine gum and lozenge. Because these medications are intended for use to prevent withdrawal, it is essential that patients adhere to a fixed dosing schedule. When the medications are used to treat withdrawal after it occurs, they are less effective because they do not work as rapidly as nicotine inhaled from a cigarette. For short-acting NRT, which are generally dosed every 1 to 2 hours while awake, patients can be advised to set an alarm on their watch or smartphone to indicate when it is time for their next dose. All medications are recommended duration of therapy, and patients should be advised to complete the full regimen to enhance their odds of remaining quit for the long term. Explaining the rationale for use of a medication to keep them comfortable while they are quitting, while they are learning how to modify their behavior, is a useful approach to helping the patient make sense of why several months of medication treatment is needed. For non-prescription medications, patients should be encouraged to carefully read the product packaging to supplement and re-emphasize what they learn from the clinician. When working prospectively with patients, it is important to assess withdrawal symptoms and adjust treatment as needed. In doing so, be cognizant of differences between the physical withdrawal and the associated timeline for withdrawal of symptoms to occur versus behavioral changes, which are best addressed with behavioral coping strategies. Some recommended language is provided in this slide. You can consider telling the patient, if used correctly, these medicines may make you more comfortable while quitting. Another example, medicines work best when taken regularly to prevent withdrawal symptoms before they occur. If you wait until you're already craving a cigarette, it may be too late. Let's now look at patient education. These are the most common side effects with bupropion. As previously discussed, there are risks and contraindications. But if you prescribe bupropion to support your patient's cessation effort, let them know that they may suffer from insomnia, dry mouth, and nausea. Less common side effects are anxiety, difficult concentration, constipation, tremor, and skin rash. Patients should let you know or call the clinic if they experience these symptoms. Importantly, let your patient know that if they are experiencing any neuropsychiatric symptoms or suicide ideation, they should stop taking ibuprofen immediately and contact a healthcare provider or clinic. The nicotine lozenge is a specially formulated nicotine delivery system that must be used properly for optimal results. Although the nicotine lozenge is used like hard candy or other medicinal lozenges, if patients chew or swallow the lozenge or consume too many in a short period of time, they increase their likelihood of experiencing adverse effects. Individuals who are unable to allow a piece of hard candy to dissolve slowly in their mouth without chewing it are more likely to experience a higher incidence of adverse effects with the nicotine lozenge. Let's look at the directions of use for nicotine lozenges. Allow the lozenge to dissolve slowly. When nicotine is released from the polyacrylamide resin, the patient may experience a warm, tingling sensation. To reduce the risk of gastrointestinal side effects, the lozenge should not be chewed or swallowed. The patient should occasionally rotate the lozenge to different areas of the mouth to minimize the potential for mucosal irritation. Lozenges will dissolve completely in about 20 to 30 minutes. The most common adverse effects associated with nicotine gum and lozenge include the following: mouth and throat irritation, hiccups, gastrointestinal complaints such as dyspepsia and nausea. These side effects are more common during the first few days of therapy. Additional adverse events associated with the nicotine gum are related to the consistency of the polyacrylamide resin, which may lead to jaw muscle ache, increased adherence to dental work, and therefore not suitable for patients with the following: extensive restorations or fillings, bridges, dentures, caps or crowns, and braces. If excessive sticking or damage to dental work occurs, patients should discontinue use. Directions for use for the transdermal nicotine patch. Choose an area of the skin on the upper body or the upper outer part of the arm. To ensure that the patch will adhere well, make sure the skin is non-hairy, clean and not oily, dry and free of creams, lotions, oils, or powder. Do not apply the patch to skin that is inflamed, burned, broken out, or irritated in any way. These conditions may alter the amount of drug absorbed. Additionally, the patch should not be applied to the skin that has been recently shaved. The patch should be applied to a different area each day. To minimize the potential for local skin reactions, the same area should not be used again for at least 1 week. Remove half of the protective liner from the patch. Try not to touch the exposed adhesive, that is the sticky side, because nicotine on hands can get into the eyes or nose and cause stinging or redness. Immediately apply the sticky side of the patch to the skin. Peel off the remaining half of the protective covering. Press the patch firmly on the skin with the palm of the hand for 10 seconds. Make sure the patch sticks well to the skin, especially around the edges. This is necessary to ensure a good seal. Additional information for patients. Water will not harm the nicotine patch if it is applied correctly. Patients may bathe, swim, shower, or exercise while wearing the patch. Some patients might ask about cutting patches in half during the dose tapering phase to save money. It is important to tell patients that they should not cut the patches to adjust the dose. Cutting nicotine patches is not recommended because the transdermal technology, that is the rate controlling membrane and drug reservoir, will be altered, which can lead to unpredictable delivery of nicotine across the skin and thus reducing effectiveness. To reduce the risk of poisoning, keep new and used patches out of the reach of children and pets. Burns from nicotine patches worn during an MRI have been reported and are likely caused by the metallic component in the backing of some patches. For this reason, nicotine patches should be removed prior to MRI procedures. After removal, the skin under the patch may appear red for the next 24 hours. If a skin rash develops after the use of a nicotine patch, or if the skin under the patch becomes swollen or very red, the patient should contact a healthcare professional. The patient should not apply a new patch. Local skin reactions such as redness, burning, and itching. These reactions are usually caused by irritation resulting from skin occlusion or from a reaction to the adhesives. Reactions are generally mild and fewer than 5% of patients discontinue therapy. Make certain patient is rotating patch application sites. Consider different brand of patch. Each manufacturer uses different adhesives. Consider treating skin reactions with over-the-counter hydrocortisone cream or oral antihistamines. Patients with dermatologic conditions such as psoriasis, eczema, and atopic dermatitis are more likely to experience skin irritation and should generally not use the nicotine patch. This is a quick guide for the prescription of medication for tobacco use cessation in this project. All patients will start with combination NRT, that is the patch which is slow acting and lozenges which are fast acting, based on the number of cigarettes a day and how soon they use tobacco after awakening. At 2 weeks, for patients that are still smoking and are eligible, we may prescribe bupropion. For patients that are not eligible, we will encourage them to try again to quit with the use of NRT. And now, as we come to the end of this module, I would like you to watch a short video demonstrating how the nicotine patch is used. Thank you. And with that, we've come to the end of this module. Thank you for participating.